be further assessment like US, more advanced techniques like EMR or ESD, and surgery could be the ideal option. So how can we manage this lesion? The lesion was located in the transverse colon. Endoscopically, a flat elevated lesion with a central depression, and the macroscopically is 0 to A plus 2C. As we need to manage according to Japanese Society guidelines for treatment of colorectal cancer 2010, American Society for Gastrointestinal Endoscopy for the endoscopic role in the staging and the management of colorectal cancer 2013, updated guidelines for Japanese Society 2014 and 2016, European Society for Gastrointestinal Endoscopy guidelines for advanced imaging for detection and the differentiation of colorectal neoplasia, and Great Britain and the Ireland guidelines for the management of non-pedunculated colorectal polyp 2015. And just 2 months ago, the most recent and the most important guidelines from European Society guidelines for phlebectomy and the EMR 2017. When we assess any polyp, we need to describe the shape by using the Paris classification system. As recommended strongly by British, Great Britain and the Ireland guidelines, whatever possible to describe any colonic polyp by using Paris classification system. And also it was the first recommendation of European Society for Gastrointestinal Endoscopy guidelines 2017. Paris classification, lesion morphology is very important, as mentioned in the previous guidelines, the British and European. Paris classification can identify those lesions with increased risk of malignancy and when we can refer patient for surgery. According to guidelines, no excuse for any endoscopist not to describe the lesion, the morphology, by using Paris and to mention it in his report. Thus we have roughly 2 types, protruded type 01, and meaning any lesion elevated from the mucosal surface more than the height of closed forceps. If we stop this pedunculated, if the top and the base have the same diameter, this meaning sessile. If the top wider than the base, this meaning semi-pedunculated. Type 02 flat, meaning any lesion below the height 2.5 millimeter of the closed forceps. Type 02A flat, elevated. Type 02B completely flat, and type 02C flat, depressed. Any lesion with depressed lesion is alarming for invasive carcinoma and could be deep submucosal invasion. A combined lesion, type 0 to A plus 2C, an elevated lesion with depressed area. The whole lesion is elevated, just with depressed area. And type 0 to C, a depressed lesion with an elevated area. The whole lesion is depressed, just with a small depressed area. Both lesions are invasive for the same findings, invasive carcinoma. Lateral spreading tumor, it's a superficial lesion more than 10 millimeter in diameter that extends lateral rather than vertically along the colonic wall. It has 2 types, granular and this homogeneous or nodular mixed type. Non-granular and this flat elevated or pseudo-depressed. This large nodule in this granular LST type is alarming for the same findings, invasive carcinoma. And also this demarcated depressed area is alarming for the same findings. The second item in the lesion assessment is the real-time histologic prediction and the assessment of submucosal invasion. This is very, very important. This is the main core of my lecture, and I think this is the most important slide in my talk. This is a collaborative study that has been done by 10 universities and institutes in Japan, concluded that the rate of lymph node metastasis is 0, in pedunculated lesion if the depth of vertical invasion less than 3,000 mic, and in sessile one if the depth is less than 1,000 mic. We'll explain more. What is the meaning by that? This is just adenomatous polyp. Here. Doesn't have any high-grade dysplasia or cancerous tissue. If there is cancerous tissue here in the head of this pedunculated, and the depth of invasion of this cancerous tissue more than 3,000 mic, will expect lymph node metastasis. If less than 3,000 mic, no lymph node metastasis. Here, it will be more than 3,000 mic, so I expect lymph node metastasis in this regional lymph nodes. And here in sessile lesion, if the depth of invasion less than 1,000 mic, will not expect lymph node metastasis. But if more than 1,000 mic, will expect. What's meaning by that? Meaning if no lymph node metastasis and I can remove this lesion, remove it endoscopically. But if there is lymph node metastasis, you cannot remove it because the patient will come to you after a few months with recurrence. So how to know this level of invasion and how accurate is your assessment? The Great Britain and Ireland guidelines 2015 strongly recommended the use of advanced endoscopic imaging to assess the submucosal invasion and to predict the histology. And also recommended by European Society for Gastrointestinal Endoscopy 2017 guidelines, the latest guidelines. So the advanced endoscopic imaging for real-time optical diagnosis and the assessment of submucosal invasion that approved by latest guidelines, it's CODIS, PET pattern, SANUS, NPI, and NICE classification. CODIS and the SANUS need magnifying endoscopy. That's, as I know, not available here in Saudi Arabia. However, the only system that can be applied, and we are validating it in Affan Hospital, is NICE classification. In 79th annual meeting of the Japan Gastrointestinal Endoscopy Society, they initiate a group that's called colon tumor, NPI, interest group, whose members include Dr. Sano and Dr. Douglas. This group provided our classification, and the key advantage of this classification as it can be applied with or without optical zoom magnification. So we can use it here without magnifying endoscopy. They classify colonic lesion into 3 types according to visits, surface pattern, and the color. Type 1 consistent with hyperplastic or inflammatory polyps. And type 2 could be adenoma, and this is very, very important. Could be adenoma, intramucosal carcinoma, or even carcinoma, but with superficial submucosal invasion. As we mentioned before, less than 3,000 mic in pedunculated and less than 1,000 mic in sessile. So if we examine this simple adenoma without any cancerous tissue or high-grade dysplasia, we'll find this. The vessels is short and thick, surface pattern is stipular, and the whole color is brown. However, as we mentioned, if there is cancerous tissue here, and this cancerous tissue confined to mucosa, doesn't invade the muscularis mucosa. Here, muscularis mucosa, this line, this intramucosal carcinoma. And if this cancerous tissue invade deeply but less than 3,000 mic, it will be superficial submucosal carcinoma. So all the 3 types, NICE type 2, meaning still I can remove it endoscopically, no need for surgery, because I don't expect the lymph node. If we examine this simple adenoma with intramucosal carcinoma or even with invasive carcinoma, but it's superficial, I'll get this view. The second view here, the up one, is irregular vessels and irregular surface pattern. You will see the opposite. If we'll see here, the invasion, more than 3,000 mic in pedunculated and more than 1,000 mic incisile, this meaning deep submucosal invasion and the expected lymph node metastasis significant. There is a risk for lymph node metastasis. You should send patient for surgery. Even if you can remove it, even if this is small polyp, very simple to remove it with simple pulpectomy, with EMR on bloc or with ESD. Don't remove it, and you should send it for surgery if your assessment was high confidence with those advanced endoscopic imaging. These advanced endoscopic imaging qualified by Japan Gastrointestinal Endoscopy Society guidelines as high accurate methods. High accurate methods. According to Japanese Society guidelines 2010, 2014, and 2016, any lesion can be resected endoscopically if there is little possibility for lymph node metastasis, and you can remove it as one piece on bloc, so either EMR or ESD. So any polyp, whatever it is size, shape, histology, location, if you can remove it as one piece on bloc, remove it, provided that no lymph node metastasis. In 2010 guidelines, maximum diameter 2 centimeters that you can remove it. But in 2014 and 2016, the size doesn't matter. Why? Because they approved the ESD for treatment of those lesions and to be implemented under health insurance. These are ECG guidelines, and that is stressed on no endoscopic role for any colonic lesion with deep submucosal invasion, as there is significant risk for lymph node metastasis. These are most important guidelines that just published. As we mentioned before, the first recommendation is polyp morphology should be described using the Paris classification system. All non-pedunculated lesions up to 10 millimeter, you can remove it with cold snare. Up to 10 millimeter, you can remove it with cold snare. No cold biopsy forceps, except if it's technically difficult because the lesion may be 2 or 3 centimeters or 3 millimeter. Any polyp should be resected, except if you have diminutive. What's the meaning by diminutive? Less than 5 millimeter. Diminutive, rectal, or rectosigmoid, that you predicted with high confidence with advanced endoscopic imaging, either nice, sinus, codus, predicted with advanced endoscopic imaging with high confidence and hyperplastic polyp. All resected polyp should be retrieved, but you can resect and discard diminutive polyp only, diminutive small polyp less than 5 millimeter, that diagnosed by NPI with high confidence in expert center. Large pedunculated polyp to remove with hot snare. However, if the polyp had more than 20 millimeter and the stock more than 10 millimeter, you should inject adrenaline